I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. Before we start, we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respect to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Great. So today we are honored to have Dr. Michael Potter speak to us on promoting health equity through practice-based research in community settings. Dr. Potter is a professor of the UCSF Department of Family and Community Medicine and a core faculty member of our UCSF's Clinical and Translational Science Institute. In his role, he directs the CTSI's primary healthcare practice-based research network and also provides consultation to support academic research taking place in community-based settings. In his own research, Dr. Potter focuses on the development and evaluation of primary care interventions that increase access to essential preventative services and chronic illness. Dr. Potter, welcome, and we really look forward to your presentation.
Thank you. And thank you for the introduction. And I'm really happy to have the opportunity to talk about practice-based research and how it can be a powerful tool to promote health equity and equitable healthcare outcomes. I think my talk will take about 40 to 45 minutes, which should give us plenty of time for questions. And can we have the next slide? So just briefly, my objectives for this talk, or my goals, are to address the following 4 questions. What is practice-based research? How does it relate to community-engaged research? What are practice-based research networks? And what are some best practices? And in the process, I hope some of you will be inspired to think about practice-based research as an important tool to advance health equity across diverse practice settings and populations. I do work within UCSF's Clinical and Translational Science Institute and direct our practice-based research network and consultation services, but I have no commercial conflicts of interest to disclose. Next slide. So I wanted to start out just by giving a little bit of history. And actually in 1962, a well-known researcher named Dr. Kerr White wrote an article in the New England Journal of Medicine describing a major problem with clinical research in the United States. And that is that tertiary academic medical centers were the main location of research ideas and subject recruitment. And he pointed out that the vast majority of research was conducted on the 1% of the population cared for at academic tertiary hospitals. And then coupled with this, research was typically done without input from the end users of the research findings in clinical settings, or the unique social, behavioral, and environmental determinants of health that may be confronted by diverse communities outside of academia. And then 40 years later, in 2001, the article was updated to emphasize that things had not changed that much in terms of where people get their care, and that's where this figure comes from. You can see that in any given month, if there's 1,000 people in the community, maybe 800 report symptoms, maybe 320 consider seeking medical care. A couple hundred might visit a physician's office, and very, very few of them ever actually reach a hospital-based setting. And of course, even as academic health centers have grown tremendously and are changing, the same is still really true today. And you can imagine that healthcare solutions developed in academic health centers may not be so relevant and accessible to wide swaths of the population, and in many cases, this type of research, though well-meaning, might exacerbate health equities rather than address them. Next slide, please. So this is, I think, a really important statement, is that practice-based research is community engagement. And if you have a chance to look up this article, it's just a very brief commentary. I think it gives a really nice summary of where practice-based research fits in the realm of community engagement. Practice-based research evolved really as a response to the need for research that speaks to the need of community-based health systems and their patients in diverse communities. And I think that this statement here sort of reminds us that the people who take care of people in diverse community settings are, in fact, an important part of the community that needs to be engaged in the research process. In other words, when we think about community-based research or community-engaged research, we should not forget about the community-based healthcare settings as an important part of the community that needs to be engaged. And I just think that can't be overemphasized, because I think this often gets lost as we think about community engaged research. It's often going straight to the community, and the community-based health settings where those individuals get care is often left out. So let's go on to the next slide. And when I think about the settings that really need to be engaged, I think of America's community health centers. So federally qualified health centers, or a federally qualified health center lookalikes, and other community health centers that are nonprofits, where 30 million Americans are taken care of, and where a lot of the disparities are seen. And these health centers, 20% of the individuals in these settings are uninsured, 59% are publicly insured, 90% are low income, 65% are members of racial and or ethnic minority groups, and 42% are in rural settings, are people who live in rural communities, another neglected patient population. So let's go on to the next slide. And I just want to share this, which is sort of a credo of practice-based research from Larry Green, who used to be a faculty member at UCSF and has developed many important tools for foundational tools for implementation science. And he has always said, if we want more evidence-based practice, we need more practice-based evidence. And I would add, if we go on to the next slide, when we think about where we are today, is that if we want more evidence-based practice that's relevant to diverse populations, we need practice-based evidence generated in places where diverse patient populations receive their care. Let's go on to the next slide. So I know, I don't know how many of you work at organizations, healthcare settings where there is a clinical and translational science institute, or are working and think of yourselves as translational research scientists, but this is a sort of a diagram that I'm sure many of you have seen about the phases of research, this linear phase going from T0, which is basic science, to translation to sort of bench to bedside to patients, and then translation into community practices, and then to the general population. And so, of course, usually when we think about practice-based research, most people sort of think, well, that's a T3 or a T4 type of process. But I do want to push back on it just a little bit, because the concept of clinical and translational science, of clinical translation, is not always sort of a linear process. So if you're doing research sort of in an academic health center, even at the basic science level, without considering the end users or those who might have trouble making use of the results of your research, even at the very early stages, your results are much less likely to have maximal impact. So if we go to the next slide, I'm going to show you a diagram of translational research, which I much prefer, from the University of Washington, which represents clinical and translational sort of as a cyclical process where there can be where that is non-linear, where human health improvement is in the center, and where there's opportunities for interactions between the academic health center and the community stakeholders in clinical settings throughout the research process. And if we go to the next slide, and in fact, I would say that practice-based research can be part of the antidote to some of the things that interfere with health equity goals of the research enterprise at all stages. And just for example, if we think about the funders of research, the priorities are often, we're all interested in community engagement here in this group, but really for years and years, and I think it still is the case even despite efforts to change things, that the priorities for where research dollars go, so really influenced quite a bit by bench science, with far less investment in thinking about how the results of that bench science will be applied clinically, much less in diverse communities. And in some cases, the priorities are skewed, even also further skewed by industries that with a profit motive or philanthropy with special interests that are not concordant with the needs of the general population. And then academic centers often yield to these same priorities because, they need the money. So that's what they're going to, if those are their opportunities, that's what we're setting up our institutions to receive this money and to use it to address those priorities that are set by funders. And in many cases, this sets up biases against researchers with non-traditional training or experience, and they don't have the opportunity to develop their own academic agendas that are independent of what the funders are dictating. And then it takes time to build the diverse research teams and be inclusive of diverse perspectives. And as a result, it can take time to to develop the credentials that allow you to advance through the academic hierarchy, and then people cut corners, and then so that means that the clinicians and the patients and the community stakeholders are often left out of the research planning process. We all have the experience of finding out that there's this great funding opportunity, but the deadline is in 3 months, but we don't have the community partnerships in place. So we make it up, and then we get the funding, and then we try to develop those relationships after the fact. And that's just sometimes the way it is, and it's not an optimal process. And then, as sort of, so that means that when the community practices are invited to be part of the research, it's often late in the process with little attention to whether the research topic actually aligns with their organizational goals, whether the research resonates with clinicians and support staff in those settings who are actually going to be doing the research. As you can imagine, maybe the head of the organization is excited to have a research project in their clinic, but they haven't even talked to their nursing staff or medical assistants who are actually going to be tasked with some of the procedures beforehand, and that can even cause problems. And then often also in these types of research structures within these things, there's often not sufficient attention given to how that's going to be paid for in the clinical settings, and whether we're asking too much of our clinical stakeholders to undertake. So if you have a robust sort of appreciation for what practices can bring to the research process, you can address some of these challenges and barriers and make your research go much better. Let's go to the next slide. So I wanted to introduce, so there's practice-based research, and then there's practice-based research networks. And there are many different kinds of practice-based research networks. Some of them are, they can be national, they can be regional, they can be local. They can involve certain types of clinics like community health centers or health maintenance organizations. There's something called the Health Maintenance Organization Research Network. There is a practice-based research of community health centers. There's several of them around the country. Sometimes they're disease focused. Sometimes they are specialty focused. And my experience is mostly working with practice-based research networks. So I'll just kind of give you a you can look at this definition of what a primary care practice-based research network is. It involves practicing clinicians in asking and answering clinical and organizational questions about primary healthcare. They draw on the experience of practicing clinicians and the healthcare team to identify and frame research questions whose answers can improve the practice of primary care. And the goal is to produce research findings that are immediately relevant to the clinician and, in theory, more easily assimilated into everyday practice. And embedded in this is the idea of creating research projects in clinical practices where there is mutual benefit, where there are trusting, non-transactional relationships that are sustained over time. And I think that just can't be overemphasized. I was delighted to hear Doria Miller's talk in preparation for this, and I know that she emphasized those same concepts as well. If you want to learn more about practice-based research networks, I do recommend you check out the AHRQ website about practice-based research networks, because there's a lot of resources there. And let's go to the next slide. And this is a resource that we developed here at UCSF, and it's on our website that can help you learn about why and the whys and hows of practice-based research. And we'll go to the next slide. And again, when thinking about health equity issues, like some of the common pitfalls of research that fails to address health equity or fails to pay attention to health equity can be addressed, I think, very well if there's a practice-based research approach. Oftentimes, it's the people in the clinical settings who take care of patients have perspectives that aren't shared by researchers, and so helping people check their hypotheses to make sure that they're free of implicit bias or unrecognized bias, making sure that if you're planning to do research in a community setting, that you're not excluding or miscategorizing certain groups of individuals. Make sure that the data collection processes that are being used, like are not going to lead to incomplete or biased results. For example, if you're doing an electronic data collection setting type of approach where most of the patients in the community don't have access to the kinds of tools that you're going to use to do outreach, the clinical teams can tell you that this is not going to work for our patients. So these types of partnerships can help you avoid problems with data collection or biases that might happen in our understanding of the data that comes back and interpreting what it means. So I think that's really an important point to be emphasized. Why don't we go to the next slide? And just some best practices. So I think we've already sort of talked about some of this, is to know who your partners are before you start. If you're doing practice-based research, ask about their priorities and about their misgivings about participation in research. As you can imagine, people in community-based clinical settings are busy, and they're paid based on the clinical service that they provide. And if they're agreeing to do research with you, that is a tremendous gift. It really needs to be aligned with their needs, and it's important to be honest about that at the beginning. because if you're working with partners who are not fully aligned with your research goals, the research is unlikely to be successful. And then think about where your partners might be able to make contributions at each step of the research process. And I think this is, people make assumptions about where those contributions can take place, and make agreements about where your partnerships will be centered along the continuum of engagement. And in other words, if you think about, and Dorianne Miller spoke a little bit about the continuum of engagement, like there is some research that requires maybe requires access to the patient population, but the research team does all the work. And then there are other types of research where you're really looking at how you're making the change is actually on the way healthcare is delivered, and that involves a lot more engagement of the staff in terms of actually doing more of the work. And it's really important that people understand how much work it's going to be, and that you understand how much work they're willing to do. And if they are going to be very involved, it really you need to respect their time and pay them fairly for their contributions and budget for it. You can't pay people to necessarily to participate in research, but you can pay people to do the things that are necessary to make the research possible. And again, this is just a very typical thing, is that researchers under budget for the partners to do the work that needs to be done to make the research successful. And I think this comes out of a sense of failing to appreciate the community stakeholder as being a true partner that deserves to be paid for their time just as much as anyone on the rest of your research team that deserves to be paid for their efforts. So let's go to the next slide. And I'm just going to go through maybe three examples of practice-based research types of activities that maybe emphasize some of these points. So at UCSF, we were fortunate to get a PCORI grant to work with community partners to identify infrastructure and resources needed to support and strengthen partnerships between community health centers, academic institutions, and community to enable it's a big mouthful, stakeholder engaged health equity COVID-19 research, and offer recommendations to support academic partnerships with community health centers. So this is a research grant that actually allowed us to develop relationships. Next slide. So we established a stakeholder advisory board with leaders from 3 large federally qualified health centers serving very large ethnically diverse communities disproportionately experiencing COVID-19. And these sites were selected from organizations. We chose these sites because they're representative of the communities that we wanted to engage with, but also because we had done prior research with these organizations. So the San Francisco Community Clinic Consortium, which is a consortium of community health centers in San Francisco. The Benioff Children's Hospital in Oakland has its own federally qualified health center that's focused on children, pediatric care. And then the Family Healthcare Network in San Francisco's San Joaquin Valley, which has a large proportion of patients who are living in rural counties around Fresno, and many of whom are migrant farm workers. The San Francisco Community Clinic Consortium was important because they serve patients who live in the Mission District, which is largely Latino, the Tenderloin, which has many homeless, marginally housed individuals, and other diverse ethnic communities, like in the Bayview Hunters Point neighborhood and the Chinatown and other neighborhoods that serve various ethnic minorities that are often not included in research. We met with 13 paid research members in 90-minute meetings 6 times over 18 months to get their input on what they thought was important. And then we can go to the next slide. And we held, they wanted to learn from us first. So we held a series of webinars that we invited them and their stakeholders to attend on COVID-19 impacts on the primary care workforce, on diagnosis and management of long COVID, and on the impacts of COVID-19 on children's mental health. And then that enabled us to develop a list of stakeholders that included clinical leaders, clinicians, and staff, and patients, and UCSF researchers that could be key informants to include in focus groups and interviews. And next slide. And then we developed a series of over 30 recommendations and presented it and discussed it in small groups here at our annual practice-based research network at UCSF that was attended by about 150 community partners, with UCSF's Vice Chancellor for Research and CTSA principal investigators and other researchers in attendance. And it was, as you can imagine, it was quite an unusual conversation because these are people who don't always hear from each other. And this is a picture of our community advisory board, the members who were able to attend. And as you can see, our advisory board included one of our associate vice chancellors for research, patients, people from the Central Valley, and so forth. It was really quite. A lot of people found it very moving, and I think if we go to the, let's see, do we go to the next slide? Let's stay on that slide for 1 second. And I think, what we really heard from this is that UCSF is, and we're committed to seeing this happen. We're committed to developing some new projects to extend these relationships and also to address some of the recommendations that were made, which means resources specifically to make it easier for UCSF researchers to work in community settings, and policies and statements about how we should be engaging with our community. The next slide, just another example of something I think Mandan has been involved with, the San Francisco Cancer Initiative, and I just think it's a really nice example of how an academic institution can invest in the community, in community partnerships, and how that can lead to very productive research collaborations that might otherwise not have been possible. So with philanthropic funds, the director of Alan Ashworth, the director of our Comprehensive Cancer Center here at UCSF, has been investing in something called the San Francisco Cancer Initiative. And the goal of that project is to reduce the cancer burden across the city by harnessing local knowledge and innovation to support action-oriented research. And early on, it was clear that if we were going to do this, we would need to have multiple organizations involved. So community organizations like the American Cancer Society, state government, but also healthcare settings like Kaiser, the Department of Public Health, and so forth. And so maybe go to the next slide. So again, it began with a similar set of processes designed to establish trust with clinical stakeholders. A series of task forces were developed. There were several initiatives and opportunities to align research with quality improvement priorities in some of the health settings. And it led to some very strong relationships with the clinical leaders at San Francisco General Hospital and the community health centers, with, I think, numerous quality improvement initiatives and research interventions that have been embedded within the health system to improve, that have led to improvements in access to breast cancer screening, colorectal cancer screening, better approaches to prostate cancer screening, with a focus on inequities a lot of the initiatives have focused on disparities that were discovered in the process. For example, low rates of screening for Black African Americans in our in the communities that are served by these clinics. So I'll do. I'm so thrilled to see Esty Hudis on this call, because I just want to share a little bit about a third theme of how practice-based research can lead to changes. So my very first research project when I was just a junior faculty member was something called the flu FOBT or flu fit program, and the idea there was that, and it's an idea that emerged from my own clinical practice, was that I was noticing that our colon cancer screening rates were really low, and our staff was not that enthusiastic about offering it to patients. Doctors were uncertain whether it was even a valuable test to use, because of colonoscopy was the thing everyone was doing, and stool tests weren't really appreciated as a valid screening option, and so people just weren't really offering it. So my idea was to develop a program where we would, since we had a really robust program for screening, for providing annual flu shots, was to pair it with for the provision of annual colorectal cancer screening, to kind of give people in the clinic and in the community the idea that just like a flu shot, if you're over 50, you need to get colon cancer screening with a FIT test every year. So that was a really successful project, especially with it. And SD was the statistician on the initial project, and we were able to get funding from the CDC and NIH and the American Cancer Society to a series of projects, both in the health department and community health centers in San Francisco, and also at Kaiser Permanente, and really showing that this is a good adjunct to care, and it really can change the way things are being done around colon cancer screening, especially in sites that aren't previously engaged. So, but what I wanted to highlight here is not so much that program, but the idea that we had when we were sharing the results back with our partners, which is something you should always do, was like, the idea was, well, like, now the research is over, what's happening now to your screening rates, and are you still doing it? Because that's often a problem when you do research, is the researchers leave and the wonderful things that you achieved didn't happen, or weren't sustained. So we went back and we did some observation and published that paper, which got the attention of some other folks and other healthcare organizations, that this was an intervention that can be sustained. And we also, another best practice, I think, we developed a website that was, shared all of our materials in adaptable, downloadable format so that people could use it. And it's still there today, even though it's like 10 years after the project. We created videos of the healthcare teams themselves in these settings doing the project, with them speaking about the project and how it helped them. And, I think, and we did a lot of advocacy, not by necessarily presenting our findings at academic research settings, but by going to national advocacy organizations like the American Cancer Society, that was a funder of our work, but also does a lot of community engaged work, the National Colorectal Cancer Roundtable, and so forth. And it led to endorsements of the project by multiple organizations as like an evidence-based practice. And now the program has been implemented in community health centers in all 50 states, and have implemented variations on the FluFit program. And I still, every fall, even though I'm not doing research in this area at all, I get email messages from community health centers around the country that are interested in trying this program. So the message there is that you can have a small project, and if done right, and you have good partnerships, and you stick with it, and you build your relationships, and you give people credit, that it can be very impactful. So I just wanted to leave you with sort of a few things about just a few final promotional messages about practice-based research and why you should do it, and just reminding yourselves that most patient care happens in community settings. So you should think about that as, if you're interested in research that affects the way healthcare is delivered, you should think about community-based practice settings as an important partner. And we still, as exciting and sexy as research can be in an academic health center with all the latest technologies, there's still a lot that needs to be learned about, just about the basic things about how primary care, how healthcare services need to be designed, managed, and implemented, in the context and desires and needs of diverse communities. Low tech, there's a lot of low tech stuff that we still can do that can really be very impactful. And then, practice-based researchers still can have really important roles, I think, to play in identifying important research questions, discovering answers, and putting the answers into practice. And I think I have one more slide, maybe. And, if you bring your clinical perspective, you're really positioned to develop truly collaborative research processes that are rooted in the experiences of your patients and communities. And I think just naturally you'll be addressing disparities and inequities in the way that healthcare is delivered, just by observing what's going on around you and the needs that you see that are broadly applicable to populations and communities that are frequently overlooked by traditional research, and that recognize and address biases that are frequently encountered in academic research. So I think that the final thing about this is that you shouldn't feel like you have to reinvent the wheel or do it on your own, because I think at every academic center that's involved in this P50 award, there probably is a Clinical and Translational Science Institute with a community engagement program that has some resources around practice-based research. There are also, if you go to that AHRQ website, you can see there are hundreds of practice-based research networks listed there. You can check and see who's doing research in your area. I think if you need to create your own wet network, and sometimes that may be the case, think about opportunities to collaborate with researchers who have similar interests to yours, so that whatever you develop, your relationships can be sustained over time. And I think you can be very successful. So I think we still have about 15 minutes for questions. Is there one more slide? Yeah. So I'm happy to answer questions. And I think there probably is a lot of expertise on this call, and among people besides myself who might also even be interested in sharing some of their answers to the questions that you may have for each other.
Thank you, Dr. Potter. This was an outstanding presentation, and thank you for sharing all these important resources with us. Maybe I'll start with a question here that's relevant to our early stage investigators. You mentioned really important information about how the approach to the community setting should be non-transactional and really trusting in a way, establishing trust. And I wonder, and I think that the first initial contact is usually oftentimes a key into ensuring that setup is there. I wonder if you have any tips for the early stage investigators as they think through approaching community-based practice settings as to, how to make that initial contact, how to do it the right way.
Right. Well, I think that's really, really important. And I think that is a case where it's good to do your homework in advance. So really know as much as you can about the health settings that you want to engage with before you even call them, and find out whether they have a history of participating in research, and whether there's anyone at your academic institution who has done research with them, or who's actually worked with them, and doesn't even have to have done research. Because I think that the if you know in advance, like, well, what are their priorities, and who do they take care of, and start really with the idea that you're asking them to tell you what they know about the topic and what their priorities are around the topic, rather than saying, I have this project, here's our abstract, this is what we want you to do. That's not going to work as well. So
No.
I think starting with a relationship that doesn't, maybe starting even before you're planning the research, to build relationships and say, hey, I'm a researcher at, I don't know, whatever XYZ institution, and I'm interested in hepatitis C research. And before I even start, I'm just interested in knowing, do you have a lot of those kinds of patients? What are the problems you're seeing? What are the challenges of those patients in your setting? And then, you know, maybe offer to say, do you need education on this topic? Because I'd be glad to come and tell you what we're doing at my institution, or just some clinical guidelines around this topic. Would that be something of helpful to you? And then, you know, build the relationship, and then ask about the research later. That's what I would say. And that's a really tall order if you're a junior investigator with a lot of pressure to be getting a grant and publishing. But it is an essential step. It's an essential step.
Thanks.
Yeah.
Thanks, Mike. That's great advice. And one of the questions I'd asked early in the chat, and you addressed, was, you know, what's the kind of the best way for early stage investigators to approach, you know, these practice-based research networks? And I thought your suggestion, like, oh, if you have a local CTSI or CTSA, that they may actually already have these relationships. I thought that was great advice. But you know, what advice if you have, you know, if you don't have access to that kind of resource, and there isn't an existing relationship with, say, you know, your local federally qualified health center network, you know, what would be your recommendations? Or maybe go back to your own career, like when you were at early stage, like, how did you start that relationship? Like, who did you actually, you know, actually call? Did you email? Like, just the practical, because sometimes it seems when you're an early stage investigator, and you know, it can feel so overwhelming to, you know, and like, who am I to like approach you for this? But how did you navigate that as an early stage investigator?
Yeah, I think that it really, you know, what really helped me was to realize that I could go beyond the immediate people in my department, and you know, just show up at conferences and meetings where people were doing the kind of work that I wanted to be, and network. And at UCSF, there were certainly, you know, there were certainly mentors, and trying to find mentors at your own institution and in other places who can help you establish those relationships is really important. I think most junior investigators do have mentors, and if those mentors are good, they should be able to help you decide which conferences to attend. So if you're interested in primary care research, you should go to the North American, in practice-based settings, you should go to the North American Primary Care Research Group Network. But if you're interested in cancer research, maybe you should go to ASPO, or one of those, you know, you know, there are conferences for these people, and oftentimes they'll have special interest groups within these organizations of people who are interested in doing that type of work. I know in like HIV work, amazing networks that have been created around HIV research, that most of the time people are thrilled to talk to you if you're a junior researcher who has time and energy to invest in a new project, a new direction, if you're bringing something to the table, you know, and have a good idea. So I don't think it has to be that hard. It just takes time.
Thank you for that. Mike, your point is very well taken about taking time. I know that oftentimes when you enter these types of settings, you are addressing some competing priorities and want to be sure that you don't interrupt or impact the workflow that is already there. You alluded to that earlier on about how important it is that it's understood that it is a gift really to be able to interact with the community in such a way, and to ensure that there's something that's given back in a way. When you think about sustainability of these types of efforts, is there any particular approach you have that allows individuals to explore appropriately their insertion into the existing infrastructure, but also what they leave behind as they move away from it?
Yeah, I think that's where practice-based research networks can be really helpful, because they, it's implied it goes beyond an individual research project. So like for our practice-based research network, we have community members or practice representatives from the community who are on our steering committee and help us plan our annual meetings. So we build relationships with these health centers, providing things that they want, like opportunities to engage and to learn, free continuing medical education opportunities. And of course, these health centers, just like in academia, there's turnover. So the person that you had this great relationship, community health centers, people come and go all the time. It takes a lot of work to nurture and keep those relationships going. So it really helps to have some sort of core infrastructure that can be the umbrella for your research project. So if you may have a project and it may be self-limited, but if you're within the context of a practice-based research network where there are other researchers coming and going, then you can leverage each other's research relationships. And again, I think the biggest challenge is like someone can go in and spoil the relationship if they're not doing it right. So that's another advantage of having a practice-based research network, because people can help you curate your relationships and help you approach things in the right way.
Wonderful. Maybe another question that comes up often is, when we do review applications from junior faculty or think about the projects that's being proposed, especially if they're pilot projects, for example, a year, or maybe the most 2 years, and thinking about feasibility of what's being proposed. What are some of the tips that you may have about, in thinking about the time it takes to really establish that initial relationship where the reviewer will sort of look at this and say, yes, that seems feasible?
I mean, I think letters of support are really important, and that's it. I think letters of support, making sure that you're not in your proposal, you're not saying, well, the practice is going to, if the practice is going to really do a lot of things that are heavy lifts, make sure that that's budgeted for, because people are not going to believe you if you say, well, the practices are going to do this. We're going to ask them, they're going to do something that's going to require a huge amount of time. If there's not sufficient evidence that they're actually going to be able to do what you're proposing, and then it's not going to be very well received. So I think, and just realizing that, not proposing anything more ambitious than you're going to be able to do it on. Research, this type of research always takes at least twice as long as you think it is. There's IRB issues, there's staff turnover, there's the people's schedules in the clinical settings don't match your schedule. Someone decides to change the way that they provide care in the middle of your research project, which can cause all sorts of problems. It's not like dealing with test tubes in a laboratory. You're dealing with human beings. So I think you have to put a lot of awareness into the fact that you're dealing with complex systems, and it does take time. I don't know what to say about it. There's no really good answer about that, except for don't be overly ambitious in your proposal.
Wonderful. One of the other things that I've faced has been, people need to be paid for their time and effort, and that's absolutely important. Some, circumstances in which you could potentially monetarily budget for that, and other circumstances where you can't. And in thinking about something to give back to the community as you are engaging with them, is there any thoughts or suggestions that you may have as examples of things that have worked, for example, in a practice setting that is similarly viewed as giving back in some ways for the time and effort?
Right. Let me just. I think. All right. So first of all, when I first was starting out in doing this type of research, I think that funders were like questioning, why are you paying these people, right? I think that has changed. And then they were saying, why are you paying them so much? And I think that's changed as well, right? So I think the payment is really important, and that should always be the first thing you think about, is paying for their time. But if, for example, like I know, like San Francisco, if it's a county health department, and you're trying to do research with them, like they may not be able to accept research dollars because they're city employees or something like that. So they may have a foundation that you can provide funding to. That they can use for other, you can some sort of an honorarium. Sometimes you can offer to do CME. There are some models now where academic institutions are actually that have these types of research. They're actually embedding academic researchers in these settings, people who are clinical, who maybe do some clinical time, but who are actually paid to do research. You can, paid like maybe 20% of their time is paid by the academic institution to focus on research. I know like some colleagues at Stanford are working on that model. I'm actually hoping to promote that at UCSF, but it's much harder to get UCSF doesn't have as deep pockets for that type of thing. But I think there's so many things. If you're oftentimes starting out, you're a clinician in those settings, so you're providing clinical care, and people are, because of the goodwill, or maybe you can provide, maybe your team has some special services that it can provide, like better access to certain types of referrals. So like community health centers are often frustrated that they can't get their complex patients into the academic health center for the kind of care that they need. So if you can help them cut that kind of red tape, that could be a real big incentive for them to want to work with you. So those are some things.
Wonderful. Those are great examples. Any other questions from the audience?
I believe there was one new question in the chat.
Please go ahead, Rochelle.
Actually, it was directly to me, but I believe this is a question for our speaker. Do you think there are funders who are more understanding of these limitations to scope and timeline?
Yes, I think actually all the major funders are really recognizing this. Of course, there's the Patient-Centered Outcomes Research Institute, which is really focusing on stakeholder engagement. I think that even NIH, some of their implementation science awards and so forth really understand that. I think that nowadays, I think the bigger issue is people dealing with their academic chairs, and sometimes people get advised, oh, don't do that. That's going to just do a secondary data analysis, then you get your papers out, and don't try to get too ambitious. I think that probably for most people who are wanting to do practice-based research, it's probably good to have a portfolio of activities, not all of which are practice-based research, so that you can show your progress in multiple ways. And actually, that's probably good to not to put all your eggs in one basket. I guess that would be my advice.
Wonderful. Well, we've reached the top of the hour, and we wanted to thank you again, Dr. Potter, for this outstanding session, and very much appreciated, and thank the audience for attending. Thank you very much.
Thank you.
Bye-bye.
Bye.